না আপনি বললেই মানাবে বলেন
আমি একটা ব্রিফ ইয়েতে কি পাঠাইছেন আমাকে?
Sir, we are live now. You can start.
Good evening, dear doctor.
Let me introduce Hafiz.
Yes, sir.
Yes. Dear
So
doctor.
can we start? Yeah. Dear participants, it is our pleasure. I mean, Dr. Chowdhury Hafiz Ahsan, to introduce him. I mean, he has been our co-director, but there are a few things that people don't know. Hafiz, I mean, everybody is Bangladeshi, but this is one person that has been a true Bangladeshi. No question about it. He goes back to Bangladesh. He has helped set up a vascular research lab at Bardem with a big grant of $500,000, $250,000. Beyond that, he goes to Bangladesh every year, participates in all activities. In America, he is professor of medicine and cardiology. In America, we don't say professor of cardiology, all are professor of medicine. He is director of the cardiac catheterization lab, and probably one of the very few directors of cardiology fellowship program at University of Nevada. He is actually he is the governor of American College of Cardiology Nevada chapter, and the only Bangladeshi that has held this position probably in whole of United States. He's my brother. We always fight with each other, but we always agree at the end of the day, and it is always a pleasure to work with him. Please welcome Chowdhury Hafiz Ahsan.
So thank you, Rohit Bhai. That was a very kind introduction, and it actually shows how much you love me. And just to tell you that recently I met Rafiq Bhai in Dallas, and he was in a great mood, and he got us some Dallas hat. And those of you old enough know about the movie serial, the Dallas. We went to see that. Wadud is nodding your head, probably reminding that you probably did not attend many of the evening third year classes and went to see Dallas, right? So it was very nostalgic for many of us. But I'm going to confine the first half, maybe 15-20 minutes, revisiting some EKGs in COVID time, because there is a surge. And then I'm keeping some EKGs for Rafiq Bhai and me to go and do the debate, as you know that I love to fight with Rafiq Bhai with EKGs. So 74-year-old with syncope, hit head, no significant past medical history. And in COVID time, there was this EKG. What do you think the EKG is?
Some junior can answer that. Our student. Please raise your hand or answer in the chat.
They called us for this EKG because there was a STEMI activation. And while you are thinking about the EKG, let me tell you that this EKG showed deep T inversion. Some, in the precordial lead ST depression biphasic classic valence. Some will say this is like a atypical valence or type B valence. But what is the rhythm? Because Rafiq Bhai is here, so we need to figure out the rhythm. This is bradycardia, but patient also passed out.
Anybody from the audience can speak, or are you calling somebody?
Please answer in the chat or raise your hand to answer.
So while Rafiq Bhai is taking care of this rhythm, we actually thought that, well, this is early experience, and then bottom line is that the cath showed that this is typical apical ballooning. We put a temporary
So there
wire.
is one answer from the attendees, sir. Dr. Muhammad Mahfuzur Rahman wrote it is 2nd degree AV block.
Rafiq bhai, you agree?
Let's go back to the ECG. So, what was your hospital diagnosis?
My hospital diagnosis?
Yeah, for the ECG.
So we mapped, and it looks like that there is P wave. You can do 2 to 1.
Yeah. So, if you look at the ECG, the bottom is the rhythm strip.
Yeah.
And first P wave, there is a P wave is bigger than the QRS complex.
Yeah.
And then there is a second P wave in the QRS complex. And the third P wave is conducted. So it looks like 2 to 1. But then if you look at, these complexes are different. Looks like here complete heart block. But I think these are ventricular escape beats, which gave rise to this prompting of acute MI. So I think its baseline is 2 to 1 heart block with accelerated or idioventricular rhythm, which making it look like complete heart block. I think I agree with the diagnosis of 2 to 1 heart block.
Right. Absolutely. So my question is that could we have avoided a cath and then do the echo and then evaluate first, and then because the patient came back COVID positive, and we just gave the supportive care, and it becomes a problem if the patient presents with bradycardia and apical ballooning, because we cannot give potentially good drug such as beta blocker. So what we do in this situation? So we don't give beta blocker. If the blood pressure allows, we can give lisinopril or ACE or ARB. And then if the patient is in heart failure, we can give decongestion diuretics. But our experience is that if you can support, sometimes even this conduction system comes back. And uniquely in this patient became sinus rhythm, and then we were not forced to put a permanent pacemaker. And because that becomes a little complicated, because the EF is bad, it will be even more a problem to address ICD or not. But just waiting 48, 72 hours, it helped us a lot. And then with same theme, I'm just building a story. 54-year-old male, hypoxic respiratory failure, full-blown COVID, BiPAP, and then in-house, this patient had a ST segment elevation. So this is our early experience. And basically what I'm trying to show you that, yes, you may see ST elevation and coronary artery occlusion in COVID, but you may not. And you may see this type of apical ballooning, full-blown apical ballooning. And then in this case, EF was bad, patient was in heart failure, and we gave the supportive care. And then patient also kind of recovered. And I'll touch base with you about what medications to give. But let me show you another patient, fever, shortness of breath, 86-year-old, and came in, found down, and altered mentation. This EKG, ST elevation in the precordial leads, and also look at these 2-3. There is also some ST elevation, and in lead 1 also ST elevation, but it is not typically concave upwards or pericarditis type. It really looks like acute myocardial injury of MI type. And then we did the angiogram, and the LAD looks okay. There is a OM disease, but good T3 flow does not explain the EKG. And then again, we ended up with the non-dominant right. We ended up with the patient with the full-blown apical ballooning. The question is that do we need to cath everybody? And if you can look at the echo, that there is typical hugging of the wall and apical dyskinesia, apical, and then this is the way the Japanese first described the takasubu. So in COVID time, we have learned that in emotional stress, the typical takasubu can be due to other surges. Now, you know, from the recent JACC, Journal of American College of Cardiology paper, that they are now calling it in stroke heart syndrome. That typically that can be, you know, different variant of takasubu, apical variety, mid-ventricular, you know, reverse takasubu. But in one thing we learned that in COVID time, regardless of the troponin rise, if you know the clinical context, then we have seen a very high number of takasubu. But that puts us in a situation that we really need to triage them right. Can we triage them right? So this is one of our paper long before COVID, and we published in 2005, and we showed that in this case, for example, ST segment elevation may be biphasic, but if you do the echo, and you can show that echo in the good clinical context, you may hold breath and may avoid a potential cath, maybe something to think about. What happens in COVID time, a lot of things can happen. It can give you thrombophilia and then acute occlusion of the vessel. It can give you plaque rupture and then full-blown STEMI. It can give you immune thrombosis and immune activation, IL-6, myocardial injury, and then stress cardiomyopathy. So how do we differentiate? EKG can be a good tool to start with. Then combine that with the comorbidities, chest X-ray, clinical pictures, echo, and then decide that whether you need to do a cath and then go further or not. This is a 94-year-old, and I was asking myself, what should I do with this patient? This patient is in the hospital for about 8-9 days and had symptoms beforehand at home, had fever, hypoxia, had troponin. But look at this, that this patient's EKG raises question about pericardial ST elevation. They call code STEMI, chest X-ray is infiltrate, could be consistent with COVID, doesn't look like full-blown failure. I did an echo. My question is, will you take this patient to cath lab with this echo and EKG and this clinical picture? You take a paracetamol along and show me that same thing that it moves good. So this is actually my echo. Show me that same group that it moves. Yeah. So my echo in the I did not take the patient, and patient got more hypoxic, and then to assure you, when the patient actually died, so I was feeling bad that I didn't take to the cath lab, and I asked, and the patient went into a PEA arrest. Rovik Bhai, if this is like a full-blown MI, the cardiac arrest in full-blown MI, the most likely rhythm would have been V-fever arrest. But the patient, you know, went into profound hypoxia gradually, and then went into a PEA, and unfortunately died. Any comment, Rovik Bhai?
No, I think the steps were appropriate. 94-year-old, there is nothing to be done for this. And you're absolutely right. If it is acute MI, you expect it to be VF, but I think probably the patient, like the example that you put before, was there an echo?
So that was my echo.
Okay. Yeah.
Did the patient receive any thrombolytics?
No, I did not give any thrombolytics. Actually, by the way, Rovik Bhai, I did not show you. The patient, when he was in the hospital for about 8-9 days, there was an echo day 2. And at that time, the LV function was normal. And this is complete apical ballooning. And their question came in, whether I should give thrombolytics. I actually told the hospitalist and the intensivist that I'm not giving thrombolytics in a 94-year-old when the suspicion for Takasubu is very high, then and she's doing poorly. And luckily, and when I was leaving the hospital, the nurse called me saying that the daughter wants to talk to me, and daughter is a nurse. And what a blessings. I talked to the daughter and I told that your mom, and she absolutely agreed with me that not give lytics. And another important thing, the follow-up troponin, you know, I know it is an after fact phenomena, but you feel good or you feel bad. If the troponin is 50,000, you know that we missed a full-blown ST elevation MI. But the troponin was less than 5. It went up, but it was less than 5. It very small. If it is a large LAD infarct, you would be expecting with that kind of wall motion, troponin to be high. Wadhu, do you agree with that?
Yes, sir. And Hafiz Bhai, if
Yeah.
it were a normal situation, would you have preferred thrombolytics?
Okay, so I give you a case example. Only last week we had a patient with a stroke. And patient came in the after fall by car accident. So patient was in trauma unit, and they called us and they are saying there is no rib fracture, there is no splenic problem, the hemoglobin is good, give lytics. And I said that it could be a stroke heart. Why you are giving lytics? You know, elderly patient, I want to take to the cath lab, but I think it is a stroke heart. So we did, and this is I'm showing you that how the contrast can be of help. If you see severe LV dysfunction with classic Takasubu in the good clinical context, hold your breath. I'm always with you. Any doubt, take to the cath lab. I don't disagree with that. But if you are sure and you can bring the team into your decision making, because everybody is learning, because you know they say, oh, they are not going to take to the cath lab. I am not strict about that, but I'm just showing you that we need to be aware and you can potentially avoid cath. So, and definitive contrast, something that you can find out. Now these newer echo machines, their acquisition is better, and you can use definitive contrast, and you can try. If you are in doubt, definitive contrast will give you a very clear picture. And again, this is ECG Basics and Beyond. ECG tells us the story, but it may not tell you the whole story. But good clinical context, think about it. Because this patient with stroke and car accident and no chest pain, you go and talk to the patient has no pain, but you have a problem with the EKG. And sometimes the patient may have pain. You may not be able to figure out, but then look at the echo, look at the whole information. Now, what do you think about this one? And first of all, what is the EKG rhythm? There is ST segment looking ugly, and then EKG is fast, tachycardia, and look at the chest X-ray. I don't think that anyone in this group will debate that this is COVID type chest X-ray, right? But there is a frothy sputum. Pulmonary edema can be like that as well, right? In the chest X-ray, you can agree. Rovik, by what you say that this is atrial flutter, atrial tach, sinus tach?
It looks like sinus tach to me. Rate is 150 because you can see a P wave before each QRS complex. So it's sinus tach, and the
honestly,
chest X-ray, of course, is kind of fluffy, infiltrate all over the place.
Right.
As you said, more like COVID rather than vascular.
And in the acute setting, right.
What is the BNP level? Can we do BNP?
Atar bhai. What is that?
True BNP level.
Oh, now I'm laughing because I make fun with the fellows that when you are dealing with acute in the emergency, don't give me troponin value. It means nothing to me. And when we are dealing with this in the acute, then BNP is good, but troponin, BNP, if these are all after phenomena, these are after phenomena. So we have no time. And I always say that echo is a very important tool. And if you see this LV, now what? Now what? So the echo is, so is it like a acute MI, ST elevation, and we take to the patient the cath lab, or we buy time? What we do? And by the way, will you call it ST elevation MI? Because if I call ST elevation MI and buy it, then I have an obligation to take to the cath lab, because our dot to balloon time, our statistics will be bad. And we are suspicious about COVID. I mean, we all are vaccinated. We can take the patient with all precautions. But question is, should we do that, or what do we do?
Hafiz, can you go back to the EKG, please?
Yes.
I mean, this ECG, if you did not give me the story with that heart rate, I'm not sure that many people will call it an acute ST elevation microinfarction, because with that level of heart rate, if somebody is having an acute MI, you will see much more pronounced ST elevation. No question, there is ST elevation. So, and of course, then clinical context, and also there is some baseline undulation. So that makes it also very difficult to, but it's not something that I look at you and say, oh my God, there is an acute MI. It's not like that ECG. Do you agree with that?
I absolutely agree. And let me, আমাদের অডিয়েন্সের জন্য আমি একটু বলি যে রফিক ভাই যেটা বলছেন is such an important statement. Rafik bhai, you just said there is ST elevation, but not ST elevations are suggestive of ST elevation MI. The pattern of the ST elevation, sinus tachycardia, a little bit of maybe interventricular conduction defect, or maybe you can call it atypical left bundle, but it does not strike as ST elevation MI. This is such an important, and then the clinical context. So maybe I called it, I deactivated. I said, this is not ST elevation MI, because I have to cover my statistics. And then I was hoping that troponin does not come 100,000 or 100, because I am hoping, because I told the ER doc, we need to stabilize. I actually gave Lasix and then control this stabilized blood pressure a little bit low, levofed, and then heart rate came down, and then bedside echo global LV. So this came out to be, COVID related stunning. So 7-8 days of this story, we actually gave this tocilizumab steroid, and then LV got better. So this is the first 15 minutes, 20 minutes of my talk. In COVID time, we need to be aware about a variety of presentation that COVID can present, and myocardial stunning, global stunning is a possibility, Takasubu is a possibility, non-ST elevation is a possibility, plaque rupture, plaque erosion giving rise to classic ST elevation MI, non-ST elevation MI, and very important, another group is hypoxia, hypoperfusion related type 2 injury, where you really treat the underlying cause and you need to address. So we need to be very careful about that, and then treat accordingly and work together with multiple disciplines, ICU doctor, primary doctor, cardiologist, and work together. So that is my first part. The second part, this is, I call it the bahas with Rafik bhai. Now, 60-year-old post-cabbage coming with shortness of breath and chest pain. So Rafik bhai, it's all yours.
Well, we have to ask the audience.
Yes, you ask the audience and you say what we should do next. So,
So
I tell you, we were dragged into this because, of course, ST elevation MI. So I go there, ST elevation MI, and everybody is looking at me to take the patient to the cath lab. And now I have this problem.
So any comment from any audience? Badut, can we get somebody or no?
Review. Can some student can enter the
Sir,
Penalty?
if you ask someone or if anyone raises their hand, I can bring that person
Okay.
to the panelist.
Oh, yeah. Can you go back? Yeah.
I think, sir, if you give them some time, they can answer in the question answer or chat box.
Anyway, so
Okay.
I'll go over this ECG, Hafiz.
Yes.
So the heart rate, the cycle length is 400, about 480 milliseconds. So it's a little bit over 120 beats per minute.
Uh-huh.
So we always think of sinus tachycardia. And of course, I'm going to come back to that. But there is a right bundle type
Yes.
with a Q wave here. So just only one lead. But if you look at lead 2, 3 AVF, I don't see anything clear, but there is a negative component.
Yes.
So I will always wonder, is it an atypical atrial flutter with 2-to-1 conduction in the slow atrial
Excellent.
flutter? Because of the P wave. And then, of course, Hafiz gave away the clue. His second ECG, if you go to the next one, please.
Yeah.
Okay, now you can see that there is a clear P wave. See positive here in AVF. So I think the rhythm before was atypical atrial flutter with 2-to-1 conduction. It's a little bit slow flutter and then converted to sinus rhythm. And that can explain the shortness of breath for the pair. We don't know how long it has been going on.
So ECG Basics and Beyond. So look at the ST elevation in the previous EKG, and then after the amiodarone, and then sinus rhythm now, and then EKG is still AVR ST elevation, but there is no profound ST depression, and then precordial ST elevation is not that bad. So I did,
Hafiz Bhai, can I ask a question?
yeah.
When the patient have bundle branch block, is the ST elevation in AVR valid?
Yes, well, that's exactly the reason I'm showing this. That particularly the clinical context. So it has to, the moons and stars has to be aligned. So if you have only AVR and there is no ST depression and you see that it came down nicely, then you don't need to pay attention. I did not take to the cath lab. His troponin came to 2.6. And remember, this is post-cabbage. And as showed, EF like 30-35%, inferior hypokinesis and inferior apical dyskinesis. So we did a cath and SVG to a small diagonal. We fixed that and everything was good. Now,
That means with
this
from
one,
this ECG,
this
Hafiz
one
Bhai,
was bad, really bad. Yeah.
that means whenever the patient have a tachycardia with the suggestion that the underlying rhythm could be anything other than sinus, we should
Yes.
try to first take the patient into sinus rhythm, then assess what is the actual
Yes.
ST segment level.
Yes, and gather more information. Get the echo if possible. Particularly, that one line is important. So three questions. You know, I told you before that Leo Tolstoy has 3 questions. Who is the most important person? The person next to you. What is the most important time? Now. And what is the most important job? The job in hand. So I tell the 3 questions in the ER. Why the patient is here? Why? So in another time, Rafiq Bhai had a very excellent comment. Patient came in with SVT. I think, no, Rafiq Bhai was not there. Ahsan Bhai pointed out this. The patient came in with SVT and patient was unconscious. And first thing Ahsan Bhai said, that doesn't explain the clinical picture. So ECG is one thing, but clinical context is even more important. So why the patient is there? Patient has any procedures, cath, echo, T, anything and then any mileage means this patient has any previous admissions in the hospitals that we can get the record from. So mileage, sometimes I'm surprised. Patient came in my hospital 3 weeks ago and nobody asked the patient. And the patient had a left bundle then and the left bundle now. And the patient coming with atypical chest pain. I'm not going to take to the cath lab. So why the patient comes to the ER, any previous mileage, and then third, any procedures. These are very important in cardiology. Okay, so this patient comes in with unconscious post-resuscitation. And what you call this, they call
We cannot hear you properly, Hafiz bhai.
mind and then deal with. We got a blood live colleague. Please take this. Their job is to just take this patient out of my ER. Will you take this patient to the CCU or cath lab?
I would just ask for the ABG and see
What is the rhythm?
level.
Absolutely. And then, blood gas was 6.9, pH 6.9, potassium was like 7, and then glucose was high. So this patient did not survive. But question to Rafiq bhai, will you call it accelerated idioventricular rhythm?
I mean, this is one of the, if you look at this ECG, you think of two things. One, severe hyperkalemia, or an agonal rhythm that patients have before they die.
Yeah.
This is one of the type of sine wave, sir.
Yes, exactly. So it's kind
Yes.
of agonal rhythm that we describe. I'm sure it's a ventricular rhythm, but I think that's the term that we have always used classically, the agonal rhythm. That
Agonal rhythm.
yes.
So I was telling our fellows that if you don't suspect hyperkalemia with this, I will penalize you.
Yes.
I definitely will penalize you. I think that has to be suspected, right? And I admit that the ER did not think about that. We gave this, but it was probably too late. So now I'm going to finish in next 5 minutes. 41-year-old, atypical chest pain, substance abuse, and this EKG. What is the diagnosis? What we do?
Can you go back to the history? Previous
Okay.
slide.
Atypical chest pain. This patient actually came from jail, substance abuse, and patient is on correct torvastatin, losartan, and clothalidone.
ECG now, please.
Yeah. So there is voltage criteria for LVH and STT changes. And I don't think that it means anything, but this is not, I think it is, I would say the T wave is secondary changes in the T wave, not primary. Primary means that the T wave, you can dissect the T wave symmetrically, but this is asymmetric T wave with LVH, and all can be explained by the LVH. There is no need for invoking ischemia. That I was trying to show. And the patient has global LV dysfunction, non-ischemic cardiomyopathy, and the question is, what do we do next?
Afid, what is the potassium level on this patient? We don't know.
Potassium was good. Actually,
Okay, good.
potassium actually low, 3.3 or 3.4.
Exactly, because you
like
see,
that.
patient
And
has
we
QT.
started on L-Doctor.
If you
QT
go
is
back
high
to the
number.
EKG, please.
Yeah. Calcium good,
Can you go back to the
potassium, we started on L-Doctor.
Okay. So this is the ECG.
ECG,
Yeah, the QT is prolonged,
Yeah.
but it's mainly because if you look at lead V3, there is a possible E wave. And the patient is on chlorthalidone. That's septic. And the other thing that happens with drug addicts, sometimes they are on methadone. So we always like to look at the medicine that can cause QT prolongation. And a lot of times methadone patients will come with cardiac arrest. And it's very, very important to pay attention to this.
this is such an important point you mentioned. So we thought that there is methadone, but he was on methadone, but after going to jail, he was not getting methadone.
Okay. All right.
So
Hafiz
but-
bhai, in our country's context, if the
Yeah.
patient have hypertension and was on diuretic, either in combination with losartan potassium or separately, it's very common to find in our patients hypokalemia.
Yeah.
I don't know. Our patients are very much salt sensitive. They always respond very well. The pressure become well controlled, but electrolyte disturbance is too high. Very often we see this.
and what I cannot tell you any study, but if you, my observation is if you give thiazide versus furosemide, thiazide causes more hypokalemia
Yeah.
than furosemide.
I agree.
Yeah. Absolutely.
I agree.
Yeah. So, and we took the chance of giving L-Doctor. The reason I'm saying this because this patient, then we find out that he was in our hospital, last year, the year before, and his EF is not improving. So this question now, will you, after looking at this, and he has been very good in terms of taking medicine, and he claims that he just started drugs again now, but he was compliant. And if you want to give a device, what device do we give?
The question would be that two things. One, we have to maximize the heart failure medication first.
Yeah.
That's important because the EF is very. What are the calculated EF, Hafiz?
It's just around 20, 25.
20,
Yeah.
25, more, nothing.
Yeah. So the role of the device is going to be to prolong his life, but optimization of medical treatment first, compliance
Yes.
with medical treatment is, and then with full 3 months of maximally tolerated medical treatment, if the ejection fraction is still less than 35%, then you have to consider defibrillator. But the question would be,
Yes.
ischemic versus non-ischemic. In America, we put ICD in everybody, but in context of Bangladesh, you have to take into consideration of the heart failure status of the patient, ischemic versus non-ischemic cardiomyopathy before deciding on a defibrillator implantation.
The patient was not getting any mineral MRA, was not getting any ARNI, and also the empagliflozin. All these three things he should be getting in proper dose, and then only we can consider that. And somebody was asking whether CRTD will be helpful, but the QS complex is relatively narrow.
Okay, so a couple of things. This is the reason I'm showing this case. Sometimes we jump on giving ICD, but in a non-ischemic, in investment world, there is a thing called return of investment. I'm investing in ICD, but return is very small here. It's non-ischemic. The chances and the indication is primary prophylaxis. I'm not arguing with secondary prophylaxis. This patient had a BP arrest, by all means, I'm for ICD. But the patient, we are talking about primary prophylaxis in a non-ischemic cardiomyopathy. The return of investment, the benefit is small. So we should argue optimization of the medications, all the medications that Professor Chowdhury mentioned. I think this is important to emphasize that. And here, the next question, if we give ICD, then don't give just single chamber ICD because of the potential beneficial drug is correct, and the patient will require the bradycardia, and then paced rhythm. So I think by the ICD will be needed. So that is even more investment and the return will be less. So I would argue that I would delay the ICD as much as we can.
Ravi sir,
Odul.
giving beta blocker with carvedilol particularly, you want to have to achieve a proper level, 25 milligram PID. But given the heart rate, how much lower heart rate can we accept?
Yeah, I mean, the point that Hafiz made, these are very, very important points. One is the role of defibrillator in non-ischemic cardiomyopathy. We need to critically look at that. Number one. Number two, beta blockers. We have to optimize. I always tell people there is nothing called low heart rate. One concern is that the QT interval, you have to look at the QT interval, but we can maximize, we can tolerate heart rate as long as the patient is not symptomatic. And as Hafiz mentioned, that once a decision is made about a defibrillator, which device? This patient with narrow QRS is not a candidate for biventricular defibrillator, but clearly a dual chamber defibrillator will help us maximize beta blocker. So no question about that part. But I think, again, we all agree in this forum that non-ischemics, we need to critically look at the role of ICD before implanting the device in these patients.
But will you consider by V?
But
I mean, no, but the question is that if we push the beta blocker, you'll be dependent on pace.
Can you go back to the ECG, please?
Yeah.
Okay. The PR interval is 160 milliseconds. QRS duration 100. So this person is not going to develop heart block. So at the best, I'm going to put a dual chamber. And then if you put a dual chamber defibrillator with minimized ventricular pacing, it will only pace the atrium, it will conduct. The only time you will put a biventricular defibrillator with a narrow QRS, if we find that the patient has AV block. That means if you believe that at a heart rate of 70 or 80 or 90, patient is going to develop 2-to-1 heart block or 1 kV block pacing in the ventricle, then yes, by V. But this QRS is fairly narrow. And I would probably
I'm showing you the medication list. Correct patient currently with this was 6.25.
Yes.
So I mean, that is a practical thing that we can go up and then see what happens and then think about it.
Exactly. I mean, I think with this heart rate is a little bit less than 60. And if we give to 12.5, it may not go down too much. And
you said little bit less than 60. It is actually 44.
I mean,
what are they?
No,
but no, go back, please. Go back, Hafiz. ECG, please.
Yeah, you can see the EKG.
Yes, so look at this. From QRS to QRS, 1, 2, 3, 5. Yeah, actually, you're right. So, but the question would be that patients still may tolerate unless they don't have dizziness. And the one thing that I do is I do not anticipate that the patient will become bradycardic. So I increase it and then decide that, yes, patient is not tolerating. We can't predict the behavior. Thank you.
So next one is a 78-year-old and then came to the hospital after pulling his suprapubic catheter. And then patient has history of dementia, obstructive uropathy, hypertension, and recurrent UTI also. Patient is on donazepam, they give it for the dementia, hydralazine, amlodipine, aspirin. And this EKG, they called us, oh, this is very ugly looking EKG, very ischemic looking, then we need cardiology. And then urology says, I'm not going to touch this patient. Let's cardiology deal with this first. Question is, what do you do? Patient is not on any beta blocker.
Okay. Can you go back to the ECG, please?
Oh, okay, yeah.
So heart rate is 37 and LVH with strain pattern. And this is a tough patient. I mean, what are you going to do? I mean, patient not on beta blocker, heart rate 37, patient cannot complain. And of course, I don't blame the surgeons because they will say, look, so, I mean, one of the things that probably I will do with this patient, I will ask the
So
surgeon.
Ravik, just to put more salt in the wound, the troponin came 0.2.
Is it high
Positive.
sensitivity or regular troponin?
High sensitivity, আমি বলতেছি 0.2 আমাদের মানে old fashion.
Old fashioned, yeah. Okay.
হাসপাতালে আসছে 200 and then current হতে 200 250 মানে 0.2 0.25.
Sure. So this is the problem. I asked one time, I asked the ER physician, why did you do the troponin?
Exactly. I was about to kill the ER physician that why the hell patient came in with suprapubic catheter pull. Why did you do troponin? But now we have a problem because the urologist is panicking with the troponin.
Yeah. I mean, this is a common problem. I don't know what you do, Hafiz, but I asked the patient first that, look, if I fix the heart, what are you going to do? Are you going to do anything with this patient?
Okay. So
That's
I tell you what I did without any
Maybe due to
without
the
any disrespect. Huh? Well, no,
What did
without
you
any
do?
disrespect. I said, okay, let me do a quick echo and I'll talk to the anesthesiologist. Because why you worry about troponin? Because you will be doing the catheter. This is the headache of the anesthesiologist. And the urologist said, that's a good point. So I talked to the anesthesiologist and because they want to do something for the catheter with anesthesia because the patient is demented, restless. So I assured the anesthesiologist the echo is good, ignore the troponin, and anesthesiologists, they know better. If you have a problem with hip fracture, don't talk to the orthopedic, talk to the anesthesiologist because the orthopedics, they don't know anything about troponin. So I mean, patient did fine, no problem. So we did not do anything.
Yeah, I mean, listen,
yeah,
we get this. The problem is that we get consultation for clearance.
yeah.
I mean, they send us patient for clearance for cataract surgery, which doesn't make any sense at all.
Yes. So cataract surgery across board, unless you are dying with MI or in active heart failure shock, cataract surgery, nothing needed. By the way, that is per board. What you do, board exam. But for whatever you do with your colleagues, it's your mutual relationship, trust, convincing. But I find it very easy sometimes that if you look at the EKG and you are confident and you do an echo at least, and then say the echo is good, doesn't look like risk-benefit ratio, it is not prohibitive, please proceed. They usually buy it. So 2 more EKG and then I'm done. So mechanical fall, and the patient is a metastatic lung CA, refractory to chemo, COPD, diabetes, and then previous PCI, and then came in with this EKG. I did have a cleaner EKG, but we suffered. So I let you suffer as well.
Misery in this company.
No, I think Hafiz, it's important because that's the real life.
Yeah.
Yeah, you can get it clear. A lot of times we end up with ECG like this and we have to make decision based on those.
So B5, B4, B5, B6. Do you agree, Rafiq, but this is sinus?
Yes, there is a P wave clearly before each QRS complex.
Okay. So they called us for a STEMI activation. I mean, sometimes I feel the ER doctors, they just came in with mechanical fall. Patient is having no chest pain. And when you ask, maybe some chest pain, but there is no distress or anything. Very lethargic patient, metastatic CA.
The people will be confused by the so-called ST elevation in lead 1.
Yes, exactly. Absolutely. So to cut the story short, because my next EKG is even more interesting. This patient, we said, this probably little pericarditis, and we found some pericardial effusion. Patient after 7 days or 10 days died. Patient was made DNR. So this is interesting, and this is the last one, and for Rafiq Bhai particularly. This patient I wish was little young, but she's 78 and came in with left knee pain and swelling, and a routine EKG was done. And my question to the audience, what is the diagnosis? AFib with Ashman's, AFib and PVC, sinus rhythm PVC, sinus rhythm PSC, and with significant ischemic change. Maybe we can open up the poll.
Yes, sir, starting the poll.
Rafiq Bhai, I'm very happy that we have still 111 attendees.
Yes.
I was scared because I may not be able to hold this.
I mean, this is an
Happy
interesting
time you have
ECG because
started
I
that
had a similar ECG a few days ago. I'm sure audience aware of the term Ashman's. That means it's aberrant conduction related to a premature beat.
This will be an interesting response. I am hoping that this will be a divided audience. Oops. Will you call it divided?
I think these are all valid choices, right, Hafiz?
Yeah, yes.
So you want to talk about it or you want me to talk?
No, I wanted to say that Ashman, you'll have to have a long, short pause. It does not follow that pattern. So Ashman is out, but underlying this PVC, and I will let you explain the PVC, but we thought that the underlying rhythm is AFib, and this PVC comes in and looks like the PVC has an inferior axis. That means it is outflow PVC and looks like left bundle. So we thought that this is a RVOT PVC, but underlying rhythm is AFib. And because the ST changes is with the PVC, we cannot call it ischemic change. So I would say AFib and PVC is the right answer.
So,
Okay.
Hafiz, Chowdhury Hafiz, I have a comment.
Yeah,
So you please see, look at the lead one.
yeah.
After the first complex, there is a clear P wave in between the two. That is the Y broad and the narrow complex P wave. Just in that is after the first complex. Do you agree?
Okay, so I will let Rafiq Bhai talk about that because
And I think, sir, I think the each narrow complex QRS are preceded by a P wave. Different morphologies of the P wave with a long PR interval.
কিন্তু আমি বলতেছি আমরা মনে করছি এটা I don't
Okay,
know
let me
what
talk.
is the right answer. These are not P wave. Rafiq Bhai, আমার কাছে মনে হয় P wave না.
Okay, so actually I saw that wave. Let's look at, there is a first PVC when it says lead 2, then narrow QRS and the PVC, narrow QRS, PVC. Let's forget about this part. Let's look from this point onward for 3 complexes. Looks extremely regular, as if it's a sinus with PVC bigeminy. However, if you look at the one before the narrow QRS R2R is different from this. And because of the bigeminy pattern, it's difficult to say irregularity of the, so there is an irregularity, number one. And then look at lead V1. There is no P wave. You see, this is all fibrillatory wave. So I had actually a similar ECG, this pattern of bigeminy in AFib. Sometimes it may give you an impression that it's regular RR interval of PVC bigeminy. Now, so I think actually this is, and look at the first two narrow QRS, and then the next one RR is different. If you measure this RR interval, you will see a variation into R2R interval of the narrow QRS. So it's clearly atrial fibrillation. Question is it PVC or is it Ashman? Now, Ashman, there are a few things, aberration. Usually, aberration is right bundle, less likely to be left bundle. Second, if you look at the coupling interval, look at the relation between narrow QRS and wide QRS. Even when it is longer, it's not any narrower. If it were Ashman, the closer it is to the narrow QRS, it will be much wider. It is not true in this case. So it is actually atrial fibrillation with PVC in a pattern of bigeminy and underlying atrial fibrillation.
And Rohit bhai,
can I ask you a question, sir?
Yes.
Yeah.
Looking at the original beat and the appearance of the PVC, the time distance between the normal beat and the PVC almost same in each beat. Is there a relationship in there?
Like, where is the PVC, Rohit bhai? Did you follow the question?
No, I did not. I just had.
Sir, the normal own beat, native beat, and the PVC.
Yes.
There seems to be a coupling interval almost similar. Is
All
there
of them?
The coupling interval.
Yes.
It seems to be very almost regular.
Okay.
Is there a relationship in there?
No, look at this. Let's start with the last QRS complex. Narrow QRS, wide QRS, distance is 400 milliseconds, two big boxes. The one before that is not actually two big boxes. It's less. So there is a little variation. Normally, a lot of times you will see a relation, and there is a concept called triggered activity. Yeah, that means a preceding QRS complex can trigger a PVC. And in those cases, you will always find a consistent relationship. But in this case, there is actually a variation in that interval. And as proven by the last two complexes, and the one preceding is different.
So Rohit bhai, my question to you is that this patient is 78-year-old. I think you probably would not pay much of symptoms to her dizziness. But in the young patient, sometimes we see this compensatory pause symptomatic. So this kind of PVC, very symptomatic. Will you consider for ablation?
I mean, the question is, when you have bigeminy, the PVC does not perfuse, and the patient's effective heart rate is become 30 or 35. These are very difficult group of patients. I mean, now that our experience with PVC ablation has increased, if it is single morphology and patient is refractory to all kind of treatment, then it should be kept in mind. Not that we're going to refer all of them, but we are now thinking about it.
Right.
Yeah. Sir, as the patient have is looking like it's a RP output track PVC, what type of antiarrhythmic will you prefer? A calcium channel blocker?
For this patient, I mean, first of all, I will not treat the PVC. That's number one. I'll look at the echo, I'll look at the substrate, number one. Number two, if there is have to be treated, calcium channel blocker is a good choice. If the patient has hypertension, that will help with the control of the heart rate also. Yes, I think that's where we have to start. And you can choose between beta blocker. My inclination is towards calcium channel blocker because a lot of these are calcium current dependent PVC, and it helps.
You mean the verapamil or diltiazem? Not exactly. Amlodipine. Yeah.
Not amlodipine. Amlodipine has no antiarrhythmic action. For the audience, if you look at the calcium channel blockers, not all calcium channel blockers work in the same site of the channel. And that defines its mode of action. If you look at the ion channel, you will find that they work in the different location. That's why amlodipine does not have much of antiarrhythmic effect. Verapamil has more antiarrhythmic effect, and diltiazem is in between. And I think we are the outgoing generation. At the newer generation, you have to pay more attention to cellular level. Please read about ion channels and cellular mechanism, because this is going to be the future of medicine, that a lot of the drugs are going to come up at a molecular level. Hafiz, any comment on that?
Yeah, so this is the dihydropyridine and non-dihydropyridine. And you can look into the L-type channel or T-type channel. But the dihydropyridines have no antiarrhythmics, no conduction system effect. The non-dihydropyridines, verapamil versus diltiazem. But verapamil's, is very side effect is constipation, so we need to be careful, and very cardiodepressive compared to diltiazem. So if the LV function normal, you can try both. But if the LV function not normal, you need to be careful about the cardiodepressive effect. But generally, diltiazem or verapamil. Yeah. Thank you. That's all I have.
No, but my question to you was, what is your comment of the future of medicine and understanding of cellular level of the mechanism of disease process and drug action for the future?
That's the huge, because it's going to be a growing thing, like individualized pharmacology.
Yes.
That's coming. That's coming.
They have already started doing it in psychiatry.
Yeah.
Choosing antidepressant according to your genetic profile.
Thank you. Fantastic talk, Hafiz, as usual.
Thank you.
I could not harass you much today.
We really enjoyed
So
it.
next time, Ravi, come with your hat.
Yes, okay.
Now, let's see. Atar bhai, would you please make some comments?
Yes, sir, will you show a few more ECG, or this will be the end of the today's session, sir?
I think I have some ECGs, but I wanted to show, because there is a lecture on hypertrophy cardiomyopathy. What is the time now?
It's 11:45.
Do we have time, or you want to stop here? It's up to you.
We can go on for another 20 minutes at least.
Okay, good. So I have to do slide share, right? What did I do? Share screen. Okay. Can you see my screen?
Yes, sir.
Yes.
So I have not many, I have few. These are very basic slideshow. The current. Okay. I'm going to skip this one. This is the one. So we'll give 20 seconds and then a question, please. The poll.
Okay, sir.
My prediction above 70%.
I hope. I think so. I think that it's.
অদূত কি হিমালয় কি বলে নেপালে গেছো?
Yes, I do. But only once.
Sir, should I give 30 seconds to answer?
Yes.
Okay.
আমি জানি না, হঠাৎ করে তোমাকে আমি নেপালের কথা জিজ্ঞাসা করলাম কেন?
Yeah. Looking at the p-waves.
40%, little less than my prediction, Ravi bhai.
Yes. So I think I'm going to go. So true. There are a few things. Number one choice is sinus rhythm with right bundle branch block. Clearly, I mean, if you look at V1, you think of that. But let's look at it carefully. If we right bundle, the QRS duration has to be long. First of all, I'm going to look at the axis. This is very basic. Lead 1. If lead 1 is positive, it will be on the blue shaded side. If it is negative, it will be on the other side. So lead 1 is negative, so it's on this side. If lead AVF is positive, then it will be below this line, and that's what it is. So it is between this and this. That means between 90 and 180 degree. So that is right-sided. And then let's take another lead. I'm going to take lead AVR. Lead 2. If lead 2 is positive, it will be below 150. And lead 2, if you look here, little positive. So it is between 90 and then I'm going to take AVR. AVR is positive. So the QRS axis between 120 and 150. So this is right axis deviation. Just a basic axis calculation. Not that you'll, but always verify that. Then look at this QRS. I have taken the V1, expanded it. Its duration is basically 100 milliseconds. So it does not fall into the category of right or left bundle, even though there is RSR pattern. It's not. Here in lead 2, you can see the P wave is big, more than 2.5 small boxes and positive. So that's right atrial enlargement. And on this side, when I expanded V1, you can see this negative portion is bigger than 1 square deep and 1 square wide. So it has biatrial enlargement. Now, so we have taken number 1 out. So it's not right bundle. And now look at this criteria for RVH, right axis deviation, which we have in this patient. RS ratio in V1 is more than 1, which is true here. R is way more than 1, so that is RVH. R in lead V1, more than 0.7 millivolt. It's here is 1 millivolt, so it's high. And then if I have RSR with V1, so this is, we have fulfilled all the criteria for right ventricular hypertrophy with biatrial enlargement. Our panelists have any other comment? Otherwise, I'll move to the next.
I'll be asking, where is the patient from? Is he from Vietnam or India?
No,
Or,
I think it's a US patient. This is Franklin Square Hospital. It's basically you find very few foreigners in this area.
Because in our country, this is the typical ECG that we can get in a mitral stenosis with pulmonary hypertension.
Yeah. Okay, so this is the next one. In the poll, I would like to see how many people answered. If we could have that also, that would be great. So this is good. Wadud, any comment on this? I'll ask Wadud, request Wadud to do this.
Sir,
I
you
think-
have given the clue because you have written down the reverse survey progression from V1, V2 to V6. That's the clue that everyone can latch into.
Yeah, but I think if you look at answer C and D, both are correct.
Yeah.
So majority of the people answered it. And can you comment on what is the meaning of reverse ROA progression, Badal, please?
In this type of ECG, I would particularly look at the lead 1 and AVR. I would have I can expect in some patients a deep negative QRS complex in V1 and negative P wave. That would be a very common case for dextrocardia. But in this case, that's not present.
Yeah. But also reverse ROA progression is a term used sometimes for acute coronary event, right?
Yeah.
That you can see that,
And-
but not in this scenario.
Yeah.
So let's look at it. I have, just for your convenience, few people answered number 1, again, right bundle. Look at the QRS duration. I expanded this V5. If you look here, 1 to 1.5 box is about 100 milliseconds at the most. And even in lead V1, it is a little bit over 100 milliseconds. So it's not bundle bind block. And there is a QR pattern here in V1. And if we look at the criteria that we used, this patient has left axis deviation, that's out. RS ratio in V1 is more than 1. And then QR pattern in V1, that's suggestive of right ventricular hypertrophy. So this is clearly right ventricular hypertrophy, and that reverse ROA progression term will be a decoration to that. But so I will take, for all practical purpose, that C and D both are correct answer, if nobody has any objection. So, but look at the QRS axis. Okay, so this one, please.
রফিক ভাই এই পেশেন্টের ডায়াগনোসিস ক্লিনিক্যাল ডায়াগনোসিস কি ছিল?
No, it's a old ECG. I don't remember this patient. Unfortunately, some of the
Sir, I would want to know if the patient has bifascicular block and RVH, what would be the ECG position in that case? Right
if
ventricular
you-
hypertrophy and bifascicular block.
Oh,
ওকে
so that's why the RSR pattern, you see, if there is RSR pattern in V1, we use this criteria. Or in
রফিক
V1
ভাই
more than 1 millivolt.
আমি একটু কই,
Bolo.
ওই যে রাইট বান্ডল হলেও তারপরেও আর ওয়েভ ভেরি টল হবে।
Yeah.
Exactly.
Yeah.
আর 2 নম্বর হলো এক্সিস নিয়ে প্রবলেম, কারণ আরভিএইচ যদি হয় রাইট অ্যাক্সিস ডেভিয়েশন করতে চাবে, কিন্তু এদিকে লেফট অ্যান্টেরিয়র হেমিবলকের জন্য দেখা যাবে যে অ্যাক্সিস নিউট্রালে চলে গেছে।
Yes.
And
কিন্তু
that's
তোমাকে
probably happened here.
Exactly.
এই জায়গায় আবার রাইট অ্যাক্সিস ডেভিয়েশন নাই, বুঝছো?
No.
No,
কারণ
no.
লিড 1 এ আপরাইট, তো এটা রাইট অ্যাক্সিস ডেভিয়েশন নাই।
Okay.
কিন্তু এটা মনে হচ্ছে অলরেডি ওল্ড পারসন হলে সিওপিডি মোস্ট লাইকলি, সিওপিডি
74.
আরভিএইচ
Probably.
70।
Okay, this one.
গুড ইকেজি রবি ভাই।
But that could be another case of posterior MI.
It's possible.
না, কিন্তু এটা পোস্টেরিয়র এমআই না।
Nah, not this one.
আমি বলেছিলাম অদুদাবা না বলে যে আরভিএইচ এর সঙ্গে পোস্টেরিয়র এমআই হলে কি হবে?
I was thinking about asking that question.
This is so interesting time, you know.
And this is very stimulating
Yeah.
because this is the small nitty-gritties that we are paying attention to, that we are not used to pay attention to.
And in medicine, one thing that we need to teach our juniors
Look
is
at
that
the poll.
logical thinking, reasonable thinking.
Yeah. And always think in terms of differential diagnosis. That Rafiq sir always emphasize this. You have to think of multiple choices. Yeah, what are the other possibilities, probabilities? this patient has very prominent U waves.
So this is good.
Yeah. Yeah.
I think this patient, I mean, sinus rhythm with left ventricular hypertrophy, but adding the STT change is a declaration that we all like because that supports the diagnosis of left ventricular hypertrophy. Sinus rhythm with left bundle branch block is not a choice because if you look at the QRS duration, it does not fulfill that criteria. It may look like it. Sinus rhythm with STT change, considered ischemia. Yes, it's a possibility, but that is not the primary reason of this. So let's look at the numbers. These are the criteria for left ventricular hypertrophy I have put in the bottom. And if you look at lead V1, S wave is 1.1 millivolt, in V5, 2.8 millivolt. So that fulfills the criteria of more than 3.5 millivolt S in V1 or in V5. Or you can take the largest S wave and the largest R wave. Largest S wave is 1.9 millivolt plus largest R wave is 2.8. That's more than 4.5 millivolt. So by both criteria, it fulfills the ventricular hypertrophy criteria and with associated STT wave changes.
There's also left atrial enlargement. That's
Yes,
also suggested.
Yes. So this one. After this, we have one more and then we're done.
Sir, just in case if the panelists want to vote, they can also.
No, the panel should not vote.
তারা আগের কোশ্চেনে কতজন আনসার করছিল?
Sir, around 38.
Good.
Not bad. Not bad.
Yeah.
64% right. We are getting there, Ravi bhai.
Yeah,
Very
I think
good.
So I think this is
Our students are getting bolder, sir. They are getting more confident,
Yes.
more knowledgeable. One of my colleagues was saying, sir, now
Yeah.
his juniors, his students are always showing him some ECGs and giving some examples and explanations. I am now learning from my students.
So after your EKG, I'll give you one interesting thing. As I was doing this, after you finish, let me have 1 minute.
Okay, so this is great, right?
Yeah.
67%. 67% said sinus rhythm, left atrial and left ventricular hypertrophy, and then there is subtle change. It's difficult to say whether it's because of the baseline movement or not, but you can see it in lead V6, V5. There is some STT change, and that should be mentioned, but it doesn't have the LVH criteria. So this, our primary diagnosis is sinus rhythm, left atrial and left ventricular hypertrophy. So let's look at this criteria. It's a little different here. So we can use many different criteria. If you look at lead V1, 1 millivolt, V5 is 1.9 millivolt, does not fulfill the 3.5 millimeter criteria. However, if you look at lead V2 S wave, which is 3 millivolt, and V5 1.9, but that makes it 4.9 millivolt, that fulfills that criteria of 4.5 millivolt, largest R and largest S in precordial lead, but also the limb leads. If you look at lead 3, S wave is 1.9 millivolt, and lead 1, 1.8 millivolt. That makes it 3.7 millivolt. R in lead 1, S in lead 3, more than 2.5 left ventricular hypertension. So this is actually a little tricky because it did not have the classic STT wave changes. This is by the voltage only, left ventricular hypertrophy. So please remember that sometimes you may not see it in the chest leads, but you can see it in the limb leads. I think we should stop there. I wanted to show that ECG just to emphasize that sometimes you may not see the classical 3.5 millimeter criteria in V1 plus V6, but you can look at the limb leads and see the LVH criteria. And a lot of the ECG machines will interpret based on those, the limb lead criteria. Okay. So thank you. I think
very interesting কাহিনী আমি যখন টক দিয়ে শুরু করছি আমার কলিগ ওই হাসপাতালের রোগী চেস্ট পেইন এসটি এলিভেশন বাই বাইফেজিক টাইপের ওয়ালেন্স বুঝছেন তার জ্বর এবং কাশি এবং ভ্যাকসিন নেওয়া বুঝছেন চেস্ট এক্স ইনফিল্ট্রেট আমি ওরে বললাম নেয়ার আগে একটা একো করো একো করে আমাকে বলে লুকস লাইক হোয়াট ইউ থিংক আই সেড ইট লুকস লাইক দ্য এপিক্যাল ব্যালুনিং টাকাসু তো আমি তখন টেক্সট করলাম যে জাস্ট হোল্ড অফ নো আই এম নট গোইং টু হোল্ড অফ আমার ফেলো এখন আমার কলিগ হয়েছে I'm not going to sit on a STEMI. So he took the patient the cath lab. Corona is normal, and now he's saying that it was a Johnson & Johnson vaccine. What I do now, I isolate myself from my family, and I'm so irritated that you are so right.
It looks like that Sohrab was in the audience. He should have come. He never spoke up.
Sohrab bhai is there. Sohrab bhai আছেন?
না মনে হয়
সে তো চ্যাট বক্সে কমেন্ট দিছে
তাই তো ছিলেন আরে Sohrab bhai কে
and so please request him next time if he is time to let us know. And
he's a very dedicated person.
Yes. So thank you. I think the Hafiz, thanks very much for the interesting lecture.
Hafiz bhai really enjoyed, and also sir example. Sir is always focal, a very focused lecture on hypertrophy, RPH, LVH, chamber enlargement. Athar bhai, will you conclude, please?
তো রিয়েলি আজকের এটা খুবই এক্সেলেন্ট সেশন ছিল স্যার এবং আমি হাফিজ ভাইকে কংগ্রাচুলেট করছি রিয়েলি ইট ওয়াজ ভেরি এনজয়েবল সেশন লার্নিং সেশন এবং আমরাও কোভিড পেশেন্ট ডিল করছি বাট উই ডিড নট রিসার্চ লাইক ইউ অ্যাবাউট দ্য কোভিড পেশেন্ট সিসিজি দিস ওয়াজ অলসো অ্যানাদার স্টিমুলাস টু আস এবং আমার মনে হয় আজকে আমাদের হিউজ নাম্বার পার্টিসিপেন্ট ছিল এভরিবডি এনজয়েড দিস সেশন পার্টিকুলারলি হাফিজ ভাই এবং হচ্ছে রফিক স্যারের সেশন এবং ফাইনালি আমাদের সাথে শেষ পর্যন্ত আমাদের শফিক আসাদুজ্জামান জামিল গোবিন্দ সবাই ছিলেন প্রত্যেককে আমি কংগ্রেচুলেট করছি এন্ড নেক্সট সেশনের জন্য আবার ইনভাইট করছি থ্যাংক ইউ স্যার উই ক্যান কনক্লুড দ্য সেশন টুনাইট টুডে
থ্যাংক ইউ
আমাদের নেক্সট স্যাটারডে সানডেতে স্যার হচ্ছে তৌফিকুর রহমান ফারুক সে আবার ইসিজি দেখাবে স্যার সেই সাথে স্যার আপনারটা তো থাকবেই স্যার
ওকে থ্যাংক ইউ
Thank you.
থ্যাংক ইউ
Thank you, sir, and good night.
Assalamu alaikum, sir. Good night.
আসসালামু আলাইকুম থ্যাংক ইউ ভেরি মাচ
Thank you, sir.